Jamila.
Good morning, everyone. It's an honor to be here this morning, and I just want to first start by providing a little bit of background about myself. It's a nice transition from Kayla's wonderful talk this morning. So my work in the field of violence against women, adverse mental health, substance abuse, and HIV spans over a decade, although my work focuses on different geographic regions. Today I'm going to focus on my work based in the United States. So I was first introduced to each of these epidemics through volunteer experiences as a young preteen abroad at a military base. So back then, it was very customary for preteens to gain summer experiences through volunteering at different offices across the base. And I spent 3 summers volunteering at the mental health clinic and the legal office. And it was in these 2 settings that where I was introduced to domestic violence. So in the mental health side of things, I was able to observe dependents, most often spouses, coming in for counseling and treatment for domestic violence experiences. And then from the legal side of things, I was able to observe accused perpetrators on trial for crimes such as sexual assault, domestic violence. And these experiences taken together really enlightened me as to the adverse mental health effects of and trauma that stems from domestic violence, as well as the role of the perpetrator in defending themselves against these accusations. Upon returning to the U.S., I then immersed myself in the area of volunteer work specific to HIV. We returned to the Bay Area, so the epicenter of the HIV epidemic in San Francisco was really enlightening to me. However, one observation that I made in volunteering in different health centers in the San Francisco Bay Area was that a lot of the resources were geared towards men who have sex with men, with limited resources focused on women, limited resources focused on women of color and other marginalized populations. So that prompted my interest to really hone my area of interest and focus on more marginalized communities. So fast forward my academic training, I then was exposed to how these linkages occur, how the linkages specific to HIV and violence intersect, both indirectly and directly, and which was led by the pioneering work of Suzanne here, who's going to speak after me. So trained as an epidemiologist, we look at numbers and we try to understand what the data is saying and draw associations and deal with odds ratios, adjusted odds ratios, regression models. That wasn't sufficient for me. So upon completing my doctoral program, I then received a Career Development Award to learn to integrate qualitative research methods, and in doing so, that would enable me also to be able to develop and implement HIV-focused interventions. So it was through my qualitative work focused on marginalized women, so women of color, women with histories of violence, women who use drugs, sex workers, that there was this common theme that these women experienced these issues, these syndemic issues that have been discussed over the past day, but they also discussed at length the social and structural factors that fueled these individual and intersecting epidemics. So some of the issues that were discussed included transportation barriers, immigration issues, racism, discrimination, medical mistrust, you name it. And these topics are topics that we do not give enough credit to and account for in the design of research and interventions. So it's something that we definitely have to do better with. So that was one key highlight from my qualitative research work. Another key highlight was that women with experiences of violence and trauma don't often, especially marginalized women, they're less likely to seek formal help through counseling services, through substance abuse professionals, HIV care and treatment if they're also living with HIV. More often, they seek formal help through this pathway of informal support networks. So they're more trusting of their friends and close trusted networks. And it's through that pathway that they may or may not choose to then ultimately seek formal help. So based on those two key findings, I then thought, well, what type of intervention would be useful for women living with HIV who are also impacted by substance abuse, violence, and trauma, and adverse mental health issues. So my team and I, we combed the literature and looked at the formative work that we had acquired, and we came up with an intervention known as Empower Women 2.0. And what this intervention is, it is a gender and syndemic responsive peer navigation program. And what we've done is combine two evidence-based approaches. So the first evidence-based approach that we have integrated is peer navigation models, which is considered a best practice in terms of HIV, engaging women living with HIV and men living with HIV to increase uptake of the HIV care continuum. And peer navigation, it can be thought of in many different ways. So you have care coordination models out there, and some of these care coordination models focus on traditional case management approaches and, provide an assessment, conduct an assessment of the patient, and identify key issues a patient is encountering and successfully links the patient to appropriate resources. There's also a model of care coordination where peer navigators are involved. These peer navigators may or may not be other people living with HIV. But what we sought to do was to utilize peer navigation in using a unique feature in that we wanted to focus on, since our population of interest was women living with HIV, also impacted by syndemics, we wanted to have peer navigators who were also not only living with HIV, but they have overcome the similar syndemic barriers that women enrolled in our project face. So we know that women living with HIV, they experience trauma at an early age. They may experience coping mechanisms, self-coping strategies through substance use. They may engage in sex work. But not only those behaviors, some women of color, also experience medical mistrust. And they have such a high level of distrust for the healthcare system that they don't engage in HIV care and treatment. So we wanted to identify peers who have experienced these particular issues, including discrimination and immigration issues, and really link our women living with HIV enrolled in our project to actual peers who have gone through the trajectory over the course of their life and navigated the system with help, of course, but they've overcome these challenges. So that's our peer navigation aspect. The second aspect of our intervention is utilizing a evidence-based STARE program that was developed by Dr. Marilyn Cloutier. And this stands for Skills Training in Affective and Interpersonal Regulation. And this training that Dr. Cloutier developed is a trauma-informed approach to help individuals develop social and emotional management of their issues focused on PTSD. So we have two evidence-based approaches combined. We have peer navigation, and then we have the STARE portion. And what we're doing is we have 100 out-of-care women. These out-of-care women are either newly diagnosed, they've never been in care, or they've been in care and they've fallen out of care. And they also have to identify experiencing one or more of these syndemic barriers. And we have a 6-month program. And so over the course of 6 months, women are matched to an appropriate peer navigator. They meet with the peer navigator, conduct an intake assessment, and decide on a method of communication that's convenient to them and that they would be engaged in to communicate with the peer, whether it be phone-based check-ins, text messaging, in-person, face-to-face meetings. In addition, another key aspect of their interaction with the peer is that they can ask the peer to accompany them to their healthcare appointments or any other appointments. So we found that women often have barriers when it comes to effectively communicating with their providers, knowing the right questions, and especially if they're experiencing medical mistrust, really navigating the healthcare system and learning to deal with that medical mistrust while asking appropriate questions related to their care. So peer navigators can accompany women to their appointments, and then the other portion of the intervention is over the course of 6 weeks, 1 time per week, women are engaged in a group session. And the group session is a little atypical. So we have a licensed clinical therapist. It's co-facilitated by a licensed clinical therapist alongside the peer navigators. So because women identify more with their informal support networks and they've built a relationship with the peer that they're assigned to, we thought it was important to include peer navigators in these sessions so they're just not standalone sessions with the licensed clinical therapist. And in doing so, it's more engaging. It allows for women to be more open, which a lot of women struggle with due to social isolation issues. And so the goals, the overarching goals, are to build skills to cope with syndemic-related affective distress, facilitate linkages with not only HIV treatment providers, but also linkages to other ancillary support service providers, such as substance abuse, domestic violence agencies, and mental health professionals. The linkages aren't just, oh, I'm going to provide you a list of referrals. It's literally utilizing contacts made through another key feature here is our community advisory board, which represents, we have a community advisory board comprised of about 25 interdisciplinary members. And these members come from a number of different local community-based agencies. So our peer navigators are well in tune with our community advisory board members and have intimate relationships with our members who then can be utilized as a link for women participating in our study who seek additional ancillary support services. The last goal of Empower Women 2.0 is to teach women interpersonal skills to activate social support networks. And this may sound intuitive and simple to us, but it is very difficult for women who are isolated and dealing with all of these social and structural conditions. And the activation of social support networks is important if a woman faces recurring experiences of violence or relapses from substance use. So ultimately, it's our goal that, and our hope that this program will function as a self-propagating system. So what that means is women who learn to manage their syndemic barriers will be able to later serve as peer navigators to other women with similar barriers. So it's something that we view could be a sustainable program. The only aspect is the STAIR training, so the skills training in affective regulation, and interpersonal regulation would be, absent. But in terms of just having someone who has been through this and has shared lived experiences, that can be fruitful in terms of making a dent in the navigation of care for women. We also hope that this is translatable to other populations. So where we're focusing on women living with HIV also affected by syndemic barriers, there are a lot of other marginalized populations in need of such programs, such as sexual and gender minorities, sex workers, transgender populations. So we view this as a starting point. It's by no means a 100% solution. There is a critical need for structural-based programs to target issues around some of the structural issues that I mentioned, such as medical mistrust and discrimination. For example, and I'm just going to throw out a few examples here, teaching medical students and residents about the cultural context of behaviors and health conditions is really critical in order to provide culturally informed care and sensitive care to marginalized populations. And that is not across the board being implemented in medical schools across the United States. So I teach a course on the cultural perceptions about health and behavior. And through this course, I have medical students enrolled, and they're just amazed at all of the information that they learn. And it's amazing to me that they're not exposed to it early on. So if we can expose medical students and residents to these issues, they're more well equipped and more willing and open to learning more about it later on and utilizing programs that are implemented to address these issues. So another example is the legal system. The legal system is an easy opportunity to, while challenging but easy on the surface, to tackle even everyday issues that women face. So women face issues around divorce, custody issues, immigration, probation, and these issues are everyday problems that women are more focused on dealing with than navigating their health care. So they will, from our qualitative work, we've shown that women will put all of that, the health care, all of these syndemics that we're talking about, that's set aside. Their pressing priority is to deal with the immediate and the here and now. So if we can develop programs that integrate these other systems to provide a more comprehensive approach for women, that would be extremely valuable. So I'd just like to close by mentioning that, there's so much to do here in the U.S. We haven't even scratched the surface when it comes to addressing social and structural factors, fueling these endemic barriers. What I didn't touch upon, but I want to close by mentioning, is we also have inequities and disparities, as you heard from John this morning, as it relates to race, ethnicity, gender, disability, even geography, that have not been accounted for in the design of programs. So we really need to be mindful of these additional inequities alongside the social and structural factors that fuel overall syndemics in the development of efficacious and effective programs. Thank you.
Thank you.